All right, let's dive into a topic that we as ophthalmologists face pretty much every day. We're talking about ischemic optic neuropathy. And, we always talk about how fragile the optic nerve is and how vital its blood supply is.
You got it. And as ophthalmologists, we see a lot of optic nerve issues, but ischemic optic neuropathy, both the arteritic and non-arteritic types, they definitely have their own unique quirks, and they really make us think carefully about how we diagnose and manage them.
That's the whole point of this deep dive today. We're going to dig into the specifics of non-arteritic anterior ischemic optic neuropathy, that's NAION for short, and arteritic anterior ischemic optic neuropathy, or AAIN. We're going to carefully go through the clinical descriptions, the diagnostic criteria, and what the latest research says about how to treat them. So first, let's take a look at NAION. What's happening at the optic nerve head? What's going wrong?
Okay, so the main problem in NAION is a blockage, an occlusion of those tiny little short posterior ciliary arteries. And when that blood supply gets cut off, it causes an infarction, like a mini stroke right there at the front of the optic nerve. It's really a localized problem, but can have a big impact on vision.
So we know that blood supply is key. But why are some patients more likely to have this kind of problem?
Well, there are a few things that make some folks more vulnerable. One thing is the structure of the optic nerve head itself. If it's crowded, meaning it has a small or even no cup, that can increase the risk. Then there's the usual suspects, the systemic issues that we always need to consider: high blood pressure, diabetes, and high cholesterol.
Yeah, those are the usual cardiovascular risk factors we're always thinking about. Anything else? Anything less obvious that we should keep on our radar?
Right, there's more to the story. We also need to be mindful of things like collagen vascular diseases, antiphospholipid antibody syndrome, and high homocysteine levels. And get this, sometimes even seemingly minor things like sudden drops in blood pressure or even something like cataract surgery have been linked to NAION. Sleep apnea is another factor that we're starting to recognize more and more.
Interesting. Even just flying or going to high altitudes, as rare as it is, can sometimes trigger it. Seems like any kind of sudden stress could be a factor in a patient who's already predisposed.
Exactly.
So when we talk about the typical NAION patient, what age are we usually dealing with?
NAION typically shows up in people over 50, but it's worth noting that they tend to be a bit younger than those who get the arteritic type. So that age difference can sometimes be a hint, a small clue when we're figuring out what's going on with the patient.
Okay, good to know. Now, how does NAION actually show up? What are the symptoms that send patients our way?
The classic presentation is sudden vision loss in one eye, and it's painless. And here's a key point. Many patients notice this when they wake up. Like, they go to bed seeing fine, and then bam, vision's gone in the morning. That's why we think it might be connected to those dips in blood pressure that happen during sleep.
Yeah, that makes sense. It's like a perfect storm. The blood pressure drops while they're sleeping, and that's all it takes to affect an already vulnerable optic nerve. So when we actually examine these patients, what are we looking for? What signs give it away?
Well, how much vision they've lost can really vary. You might be surprised to hear that about 30% of them have almost normal vision, just a slight decrease. But for most, the vision loss is more moderate to severe. When we look at their visual fields, the most common pattern is an inferior altitudinal defect. But we have to remember it's not always that straightforward. We can see central defects, paracentral, quadrantic, even arcuate defects, so we got to be really thorough with our visual field testing.
And what about color vision? Does that help us differentiate NAION from other optic neuropathies?
Absolutely. Color vision, or rather the loss of it in NAION, tends to match the degree of their vision loss. If their visual acuity is down by a certain amount, their color vision is usually affected to a similar degree. And this is where it gets interesting. This is different from optic neuritis, where color vision can be way off, even if their visual acuity seems pretty good.
That's a really useful point. So color vision helps us tease these conditions apart. Okay, when we take a look at the optic disc itself, what's going on there in NAION? What are the key signs?
In the early stages, we'll usually see a swollen optic disc. It can be diffuse or just in one sector, and it often looks kind of flush, congested. We might also see a few of those splinter hemorrhages around the disc. Think of them as little flame-shaped bleeds right at the edge, like what you see in figure 19.13.
And over time, does that initial appearance change?
Yeah, that swelling goes down over a few weeks, maybe 3 to 6 weeks. As it resolves, the disc starts to look pale. So that change in the disc appearance is like a timeline of the whole event.
So we go from a swollen red disc to a pale one over time. Okay, that's pretty clear. Now, let's say we're suspecting NAION based on what we've seen and heard. What tests are we ordering? What are the absolute must-dos?
No matter what, we're checking their blood pressure, doing a fasting lipid panel, and getting a blood glucose test. We got to rule out the usual suspects. But in this age group, there's a really big one we can't miss. Giant cell arteritis. Remember, the age ranges overlap, so we have to be extra careful not to miss GCA.
Absolutely. And we'll get into GCA in just a bit. But yeah, we can't overstate how important it is to rule out GCA in anyone over 50 with sudden vision loss. The risk of permanent blindness in the other eye is just too high.
Exactly.
So are there any other tests we should consider for a typical NA-ION case?
If it looks like a straightforward NA-ION, those blood tests are usually enough. But if things are a little weird, let's say the vision loss is super severe, it hits both eyes at once, which is rare in NA-ION, or there are neurological signs, then we might need to do some neuroimaging. An MRI of the brain and orbits can help us rule out other things that could be causing the optic nerve problem.
Okay, that makes sense. So we've diagnosed NA-ION. Now, what do we tell our patients? What can they expect to happen with their vision?
Well, the good news is that most people with NAION see some improvement in their vision, but we have to be realistic about how much they'll recover. About half of them will end up with pretty decent vision, 20/30 or better, but unfortunately, about a quarter will have more significant vision loss, like 2200 or worse.
And what are the chances of it happening again? In the same eye, or even more concerningly, the other eye?
The risk of having another episode in the same eye is low, something like 6%. The bigger worry is the other eye. About 10% of patients will have the other eye affected within 2 years of the first one, and that jumps to 15% within 5 years. So it's really important to talk to patients about that possibility.
Yeah, that's a huge concern. So how do we actually treat NA-ION? Can we do anything to improve their vision or stop it from getting worse?
Honestly, this is where NAION gets frustrating for both us and the patients. There's no magic bullet, nothing that's been proven to change the course of the disease. We used to think optic nerve sheath fenestration, that's a surgery to relieve pressure on the optic nerve, might help, but studies have shown that it doesn't really make a difference in the long run.
What about steroids? I know there's been some back and forth about using them in NA-ION.
Yeah, some doctors believe in giving a short course of steroids right when the NAION starts, within those first few weeks. But the evidence isn't really there to support it. Studies haven't shown a clear benefit in terms of final vision. So, while some may use them, it's still up for debate.
Okay, so if there's no proven treatment for the NA-ION itself, does that mean our focus shifts to managing those underlying systemic risk factors we talked about earlier?
Exactly. We got to get those things under control. High blood pressure, diabetes, high cholesterol, those need to be managed aggressively. Now, it hasn't been proven to directly prevent NAION or stop the other eye from getting involved, but it's just good practice for overall vascular health.
And aspirin, that's often prescribed for general vascular protection. Does that play a role in NA-ION?
That's a good question. Aspirin definitely helps lower the risk of heart attacks and strokes, so it's often given to patients who have had NAION. But here's the thing. It doesn't seem to protect the other eye from developing NAION, so it helps with overall vascular health, but not specifically with NAION.
All right, so that's NA-ION in a nutshell. Let's switch gears now and talk about aortic anterior ischemic optic neuropathy, or AAION. As the name implies, inflammation is a big part of the problem here.
Right, you are. AAION is directly caused by giant cell arteritis, also known as GCA. And GCA is a whole different ballgame. It's a systemic inflammatory vasculitis, meaning it affects blood vessels throughout the body, not just in the eyes.
Now, we often hear about polymyalgia rheumatica, or PMR, in connection with GCA. Can you break down that relationship for us? How often do we see these two conditions together?
Sure. GCA and PMR, they're like two peas in a pod. About half of the patients diagnosed with GCA also have symptoms of PMR, and the other way around, about 20% of folks with PMR end up developing GCA. The hallmark of PMR is pain and stiffness, mainly in the shoulders and hips, and is usually worse in the morning. And here's a key point. PMR usually responds really well to low or medium doses of prednisone, but even though they're so closely linked, we still don't fully understand what causes both of them together.
So even though we know they often occur together, the exact connection is still a bit of a mystery. Now, let's zoom in on diagnosing GCA itself. What's happening under the microscope in those affected arteries?
If you were to look at a biopsy, like in figure 19.14a, you'd see that GCA is what we call a granulomatous necrotizing arteritis. That's a mouthful, but it basically means there's inflammation with these clumps of immune cells called granulomas inside the artery walls, and that inflammation causes damage and ultimately death of the artery tissue.
So which blood vessels are most often hit by this inflammation in GCA?
GCA loves to attack those large and medium-sized arteries, particularly the ones branching off the aorta. Also, the superficial temporal arteries, the ophthalmic artery and its branches, including those posterior ciliary arteries and the proximal vertebral arteries. Interestingly, the arteries inside the skull are usually spared. We think that's because they have less elastic tissue in their walls, and that elastic tissue seems to be a target for GCA.
Now, are there any particular risk factors that make someone more likely to get GCA?
There are a few things that might increase the risk, like smoking, having a low BMI, and early menopause in women. But the biggest factors are age and being female.
Yeah, it's definitely an older person's disease. What's the typical age range we see?
The average age at diagnosis is around 70, and it's extremely rare to see it in someone under 50. And women are about 4 times more likely to get it than men. So if an older woman comes in with these symptoms, GCA has got to be top of mind.
Okay, so older woman, new symptoms, GCA red flag is going up. How do we actually make the diagnosis? I know the American College of Rheumatology criteria are important here.
You're right. The ACR criteria are really helpful. They give us a framework for classifying patients, especially for research. But they're also useful in our everyday practice. Those criteria include things like age over 50, a new headache, a tender or weak temporal artery pulse, an ESR of 50 or higher, and of course, an abnormal temporal artery biopsy showing the classic signs of vasculitis. They even updated the criteria in 2022 to include the halo sign on a temporal artery ultrasound, which can be helpful. If a patient meets at least 3 of these criteria, the likelihood of GCA is pretty high.
Those criteria give us a good starting point. But beyond those, what specific symptoms should really make us think GCA, especially in someone with vision loss?
There are a few things that should set off alarm bells. Scalp tenderness is a common one, especially when they're brushing their hair. New headaches are frequent too, and they can be in the front, back, or side of the head, or even all over. Then there's jaw claudication, which is pain in the jaw muscles when they chew. That one's almost a dead giveaway for GCA. We should also watch out for more general symptoms like weight loss they can't explain, fever, sweating at night, just feeling blah, and even depression. And of course, if they have double vision or develop AAI on, those are big red flags.
Yeah, jaw claudication, especially in this age group, that's a huge red flag.
Mm.
Even before any vision problems show up, are there other signs we might see on exam that point to GCA?
We should always pay close attention to those temporal arteries. If they're thickened, tender, inflamed, maybe even bumpy, like in figure 19.1 TB, that's a sign. But sometimes it can be subtle. Feeling for the temporal artery pulse is key too. Early on, we'll usually feel it. But as the inflammation gets worse, the pulse might get weak or disappear altogether. A missing or weak pulse in an older person should make us think GCA right away. And don't forget about eye movement problems. We can sometimes see things like ocular motor palsies, including third nerve palsy that affects the pupil. And in rare cases, GCA can really do some damage to blood vessels throughout the body. We're talking about things like scalp gangrene, dissecting aneurysms, problems with the aorta, heart attacks, kidney failure, even stroke in the brainstem.
Wow, that's scary stuff. It really highlights how important it is to catch and treat GCA early, not just to save their vision, but to prevent all those other complications. So let's talk about testing. We know the ESR is a key part of the ACR criteria, but what other blood tests are helpful?
The ESR is often way up in GCA, usually over 60. But here's the catch. About 20% of people with GCA have a normal or only slightly high ESR. So a normal ESR doesn't mean we can rule it out. The C-reactive protein, or CRP, is another marker of inflammation that's usually elevated in GCA, and it tends to track better with disease activity than the ESR. If we do a complete blood count, we might see a high platelet count, and that's actually a better predictor of GCA than the ESR or CRP. And anemia is common too. Liver tests can be abnormal in about a third of GCO patients. The usual autoantibody tests like ANA or rheumatoid factor aren't really helpful for diagnosing GCA itself.
So we get some clues from blood work, but what about more definitive tests? I know a temporal artery biopsy is still considered the gold standard.
Absolutely. If we strongly suspect GCA, we don't wait for the biopsy. We start steroids right away. Ideally, we do the biopsy within 3 days of starting the steroids. Now, long-term steroid treatment, like more than a week or 10 days, can sometimes mask the inflammation in the biopsy, but not always. We can still see it. When we're doing the biopsy, if the patient has eye symptoms, we usually take it from the same side as the affected eye. And we prefer to biopsy from the temple area because it's safer. We need at least an inch of the artery, and the pathologist needs to look at multiple sections because GCA can cause these skip lesions where there are patches of inflammation with normal areas in between. So a negative biopsy doesn't completely rule out GCA if the clinical picture really fits. Studies show that the biopsy is positive about 77% of the time, meaning there's about a 1 in 5 chance it could be negative even if they have GCA. And sometimes, if the first biopsy is negative and we're still suspicious, we might do a biopsy on the other side, which can be positive about 5% of the time.
That whole skip lesion thing makes a lot of sense. We need enough tissue and careful examination to catch those areas of inflammation.
Now, what about imaging? I know temporal artery ultrasound is being used more and more for GCA.
Yeah, ultrasound is a really useful tool. It's non-invasive and can show us that halo sign in about 75% of GCA patients, which is that dark ring around the artery on the ultrasound image. The halo is basically swelling in the artery wall. So in experienced hands, ultrasound can be a good alternative to biopsy in some cases. But we got to remember that halo sign isn't unique to GCA. We can see it in other conditions too, like atherosclerosis, so it can give us false positives. But it's still really helpful for guiding us to the right spot for the biopsy, especially if the artery is hard to feel because of inflammation.
So ultrasound can be a great tool, both for maybe diagnosing GCA without a biopsy and for guiding the biopsy when we need it.
Are there any other imaging tests we should consider for GCA?
Since GCA can affect bigger arteries too, not just the ones in the head, we might need to image the aorta and its branches. We can use ultrasound, MRA, or even a PE scan. This helps us look for aneurysms or dissections, which can happen when the aorta is inflamed. And because those are serious complications, we need to follow these patients long-term with imaging. And there's some new research suggesting that imaging the shoulder joints, either with MRI or ultrasound, could be helpful in diagnosing PMR.
It sounds like diagnosing GCA takes a village. We need the clinical exam, blood tests, imaging, and sometimes the biopsy to really nail it down. Now let's move on to treatment. Let's say we have a patient with GCA but no vision loss yet. What's our go-to treatment?
The first thing we do is start them on prednisone, usually 1 milligram per kilogram of their weight per day. How long they stay on it and how quickly we taper them off depends on how their symptoms are doing and what their inflammatory markers are showing. We need to watch both of those things closely because they don't always match up perfectly. Most patients need prednisone for a long time, like 1 to 2 years. And some people need a low dose forever to prevent it from coming back. We try not to taper the prednisone too quickly, especially when we get below 10 milligrams a day, because that increases the risk of a flare-up. The CRP level can be really helpful for monitoring their response to treatment because it tends to change faster than the ESR when we adjust the prednisone dose.
Okay, so we've got a handle on GCA treatment. Now let's tackle AIRN. We know it's a serious complication of GCA. How often does it actually happen in untreated GCA?
AION develops in a lot of patients with untreated GCA, somewhere between 30 to 50%. And here's the scary part. Of the folks who get AION in one eye, about a third will get it in the other eye, usually within a week. Posterior ischemic optic neuropathy is less common in GCA, but we still need to be aware of it.
That potential for quick and bilateral vision loss is what makes AION such a nightmare. What kind of symptoms should make us think of AION right away?
Patients often describe it as a sudden and profound loss of vision in one eye, and it's usually painless. Sometimes this is preceded by brief episodes of blurry vision or complete vision loss, what we call amaurosis fugax. Double vision can also be a warning sign, and many patients have pain in or around the eye. While most people with AION also have those typical GCA symptoms we talked about 20% don't have any or have very mild ones, so that can make it tricky to diagnose. It's also possible, though rare, for both eyes to be affected at the same time, and we're always worried about the second eye getting hit quickly, which could lead to complete blindness, so we gotta act fast.
So sudden, severe vision loss in an older person, especially if there's been any blurry vision or double vision and maybe some eye pain, that should send up a huge AION red flag. What about the eye exam? What do we typically see?
The first thing we'll notice is that they've lost a lot of vision. The pattern of their visual field loss can vary. Often it's altitudinal, depending on which blood vessels are affected. Now, when we look at the optic disc, this is where it gets interesting. We usually see this pale, almost chalky white swollen disc. That paleness is a big tip-off that it's AAION, not NAION, where the disc is usually red. Over time, maybe a month or two, that swelling goes down, but unfortunately, the disc becomes very atrophic and the vision loss is usually permanent.
That pale, chalky white disc, that's a crucial finding. So how's the outlook for someone with AAION? Is there much chance of getting their vision back?
Sadly, the prognosis for vision in AA-ion is generally not good. The vision loss is often permanent and severe. There are rare cases where early treatment with high-dose steroids can help them recover some vision, but that's not the norm. Our main goal with treatment is to save the vision in their other eye and prevent any other problems GCA might cause.
Yeah, protecting that other eye is the priority. And we're talking about high-dose steroids here. So even with treatment, there's still a significant risk to the other eye, isn't there?
You bet. Even if we start steroids right away, there's still about a 25% chance the other eye will be affected. So we hit it hard and fast with the steroids. We usually start with IV methylprednisolone, like 500 to 1,000 milligrams a day, for 3 days. Then we switch them to high-dose oral prednisone, usually 1 to 2 milligrams per kilogram of their weight per day, for the first 3 days. After that, we drop the dose down to a maintenance level, something like 50 to 60 milligrams a day, or at least 0.75 milligrams per kilogram, and keep them on that for 4 weeks or until their symptoms are gone and their lab tests have normalized. And then comes the long and slow process of tapering them off the prednisone. We have to do it gradually, based on how they're doing clinically and what their inflammatory markers are showing. A common way to do it is to lower the dose by 10 milligrams every 2 weeks until we get down to 20 milligrams. Then we slow it down even more, maybe lowering by 2.5 milligrams every 2 to 4 weeks until we get to 10 milligrams. And then from there, we might go down by just 1 milligram every 1 to 2 months.
That's a lot of steroids for a long time. We have to be really careful about the side effects, especially in these older patients.
Absolutely. We might use enteric-coated prednisone if they have a history of ulcers, and everyone on high-dose steroids needs to be on meds to protect their bones and stomach. We usually give them a weekly bisphosphonate, calcium and vitamin D supplements, and a proton pump inhibitor. And close monitoring is key. We need to keep a close eye on their blood counts, their ESR and CRP, their electrolytes, their blood sugar, and their blood pressure at each visit. We might also do a chest x-ray or other imaging to look for an aortic aneurysm, and we need to check their bone density to monitor for osteoporosis.
So aside from steroids, are there any other medications we use for AAI on?
We typically start them on aspirin too, a big dose at first, like 600 milligrams, and then a daily dose of 100 milligrams. Aspirin can help reduce the risk of further vision loss and stroke. And if their symptoms come back while we're tapering the steroids, we bump the steroid dose back up right away. If they have vision problems again, we might even give them another round of IV steroids. For those who don't respond well to steroids or can't tolerate the side effects, we might add other immunosuppressants like methotrexate. But the evidence for those isn't as strong as for steroids. There's also a newer drug called tocilizumab that's showing some promise. It blocks a particular inflammatory pathway and seems to be helpful in people who have GCA that keeps coming back or isn't responding to other treatments. It can also help us taper the steroids more quickly.
Okay, so treating AI on is a balancing act. We're trying to control the inflammation and prevent further damage while minimizing the risks from long-term steroid use. Now, I know there are a few other less common eye problems that can happen with AAI and GCA. What are those?
Right. Sometimes we see a ciliaretinal artery occlusion along with AAIN, and sometimes we'll see a central retinal artery occlusion, often with blockages in other arteries that supply the choroid. It's rare, but GCA can also affect the ophthalmic artery itself, causing what we call ocular ischemic syndrome. Another thing to be aware of is something called pseudo-Foster-Kennedy syndrome. It's basically when a patient has ischemic optic neuropathy in one eye, either NA-ion or AA-ion, and optic atrophy in the other eye from some other previous problem. We have to be careful not to mix that up with true Foster-Kennedy syndrome, which is usually caused by a tumor in the brain.
Yeah, it's important to keep those other diagnoses in mind. And finally, let's touch on posterior ischemic optic neuropathy, or PIN. How is that different from the anterior forms we've been talking about?
PIN is less common than those, and it involves the part of the optic nerve that's behind the lamina cribrosa. It's a diagnosis of exclusion, meaning we rule out other things first, like tumors or inflammation. A big clue with PIN is that the optic disc looks normal at first, and the paleness develops over several weeks. There's also a type of PIN that can happen after surgery, especially heart or spine surgery. It's rare, but it can happen, especially if the patient has anemia or low blood pressure during surgery. It often affects both eyes, and the visual prognosis isn't great. We might need to transfuse them and treat any swelling. And just like with anterior ischemic optic neuropathy, there's an arteritic form associated with GCA and a non-arteritic form. The arteritic kind has a poor prognosis, while the non-arteritic kind usually has a similar prognosis to NA-ion. Some doctors might give a short course of high-dose steroids for the non-arteritic type, but the evidence for that isn't very strong.
So the normal-looking disc early on is a key feature of PIN. And the link to surgery is interesting. Well, this has been a really thorough look at ischemic optic neuropathy. It's clear that even though both NION and AION involve problems with blood flow to the optic nerve, the underlying causes, how they present, and most importantly, how we manage them are very different. And we can't forget about that elephant in the room, giant cell arteritis with AAION.
I completely agree. As ophthalmologists, we always need to be thinking about GCA in older patients with sudden vision loss. It can progress quickly and affect the other eye, and it can cause serious problems throughout the body. Early diagnosis and treatment are crucial. We need to start those steroids right away if we suspect AI to protect whatever vision they have left.
Couldn't have said it better myself. And this is a field that's always changing. We're learning more all the time. With new tools like temporal artery ultrasound and new treatments like tocilizumab, it makes you wonder, how will our approach to diagnosing and treating AION evolve in the next few years? What can we do to get even better at saving our patients' vision? It's something we all need to keep thinking about and stay up to date on the latest research. Well, thanks for joining me for this deep dive. It's been great having you.
My pleasure.
It's a topic that's near and dear to all of our hearts as ophthalmologists,
Yeah.
and I think we covered a lot of really important ground today.
We did.
So until next time, keep those eyes healthy and those minds sharp.
And those temporal arteries palpated.
Absolutely.